Good morning, good afternoon, and good evening, everyone, wherever in the world you may be joining us from today. My name is Francesco Del Carpio, and I am the CFL York Operations Coordinator. I would like to officially open the sixth session of the Emergency Management in Hospitals and Healthcare Speaker Series with a land acknowledgement. We acknowledge and recognize that many Indigenous nations have long-standing relationships with the territory upon which our campuses are located that precede the establishment of York University. The area is known as Takaranto and has been caretaken by the Anishinaabe Nation, the Haudenosaunee Confederacy, and the Huron-Wendat. It is now home to many First Nation, Inuit, and Métis communities. We acknowledge the current treaty holders, the Mississaugas of the Credit First Nation, and that the territory is subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. As this is an online event and our participants may be joining from various locations, I strongly encourage you to learn about the traditional land upon which you are located. With this, I welcome our moderator, our speakers, and our participants from around the world. Welcome to our webinar. Without further ado, it is my great pleasure to introduce our moderator, Misha Richard. Misha Richard is the current Emergency Preparedness Lead for the Thunder Bay Regional Health Sciences Centre in Thunder Bay, Ontario, Canada. In this role, she acts as a subject matter expert, assisting with the development and maintenance of emergency management governance, training materials, and exercises. Misha also volunteers as an editor for the Canadian Journal of Emergency Management and is happy to be a collaborator and facilitator for the CFL York series. She holds a Master's of Disaster and Emergency Management degree from York University and bachelor's degrees from Western University and Brandon University in the focus areas of political science and disaster studies. Misha, thank you very much for moderating today's session. The floor is yours.
Hello, everybody. So we did have a little bit of a tech issue. Thank you for the introduction. I want to start off with just a brief moment of general housekeeping, and then I will introduce our speakers that I'm very excited to have with us today. So to start off, again, housekeeping for anybody that hasn't joined one of these sessions previously, we obviously encourage you to have a conversation going in the chat. However, if you have direct questions, we request that you put those into the Q&A so that myself as moderator can keep track of your specific directed questions. Also, because our speakers today really need to make use of the full 40 minutes to get all this fantastic information and learning out to you, we're going to have to reserve uptake of questions to the end of the speakers' presentations. So again, it doesn't mean we're not going to get to those Q&A, but make sure you're populating them in there as they come to you, and we'll filter through those and we'll address them with our speakers when we get to the conclusion of the presentation. So now I get to say without further ado, I'd like to introduce first Moira Hennebury, who's the manager of emergency preparedness at Sunnybrook Health Sciences Centre and co-chair of the Toronto Region Health Emergency Preparedness Committee. So in 2019, no small feat, Moira co-led the development of Exercise GTA Unified, which involved 34 participating agencies, including 22 separate hospital sites, making it the largest health sector-focused mass casualty incident exercise ever conducted in Canada. Moira is an associate business continuity professional and holds a Master of Disaster and Emergency Management from York University and a Bachelor of Environmental Studies from the University of Waterloo. And co-presenting today, we've got Jayme Paterson. So thank you as well. She's an emergency preparedness specialist with Sunnybrook Health Sciences Centre and co-chair of Sunnybrook's Code Orange Steering Committee that you'll hear more about in this presentation. She holds a Master's of Disaster and Emergency Management from York University, where she completed original research on organizational learning and mass casualty incidents. Before joining Sunnybrook, Jayme worked as a registered nurse in the emergency department of the Hamilton General Hospital, and has a Bachelor of Science in Nursing from McMaster University. So thank you so much for speaking to us today on this really fascinating, exciting topic. Since you need the full 40 minutes, you're free to kick off.
Thank you. Let me just share my screen. Can you confirm you can see? Okay, thank you so much.
Awesome. Well, thank you so much for having us today. My name is Moira Hennebury. Again, I'm joined here by my colleague, Jayme Paterson. The topic of our presentation is on the mass casualty hazard, and we're hoping to share with you some of the tips and tricks, planning structure, and so forth on how we plan for MCIs, which we hope to be infrequent emergencies. In terms of an agenda, oh, sorry, Jayme. I'm going to kick us off with an intro to Sunnybrook and Code Orange. Jayme's going to take us through the bulk of the presentation in terms of our governance and oversight structures, our planning structures, and some of the activities we do to lead preparedness. And we're going to close off with a few discussion points on regional preparedness. And happy to share that we're going to end the session with 5 things that we think everyone here can take away and implement at their organizations, acknowledging that a lot of this planning happens over a long period of time. But first, to introduce you to Sunnybrook. Sunnybrook is an academic health sciences center that is fully affiliated with the University of Toronto. We have 10 locations, with our largest campuses located in Toronto, Ontario. Operationally, as you can see on the right-hand side of your screen, Sunnybrook is organized programmatically, and our 10 programs share a very common mission, which is to invent the future of healthcare. So no surprise, my team here at Sunnybrook is fundamentally interested in inventing the future of healthcare emergency management. Our Tory Trauma program is the largest trauma program in Canada, and we are very proud to share that just this year, we became the first center outside of the United States to become verified as a level 1 trauma center by the American College of Surgeons. We are also home to Ontario's only full-service burn program. As you can imagine, our emergency department is one of the busiest in the province, caring for the highest level, or highest volume, of life-threatening cases in the province. So our position, our services, and our role are very important elements to our preparedness story. We do have a dual mandate as an organization, both to serve our local community in North Toronto, but also to provide specialized care for the entire province of Ontario. We are a critical infrastructure that operates 24/7, 365 days a year, and so the cost of underpreparedness is quite high. In today's presentation, we're going to talk about, of course, the mass casualty hazard. For those of you that are joining us, perhaps from organizations outside of Ontario or non-healthcare organizations, the color codes in Ontario are standardized by the Ontario Hospital Association. Code Orange simply refers to an external disaster. I can confirm, certainly within the Greater Toronto area, most of our hospitals do go a bit farther in defining that as any external disaster causing a no-notice surge in patients that is overwhelming the hospital's resources and normal functioning. Something important to note is that this definition doesn't really have a number assigned to it. The threshold to trigger a code orange at any hospital is really a function of what that day looks like, available resources, and the types of injuries they've received. I think if you're joining us today and you're coming from a hospital, we know that our communities have the expectation that we are prepared for these types of events. They are infrequent, which challenges the planning for them. But we hope today, by sharing our model and approach, that we can impart some tips and tricks for all of our colleagues in terms of implementing either a similar program or activities at their organizations. So without further ado, I'll hand it over to Jayme to walk us through our structure.
Thank you, Moira. So good morning, everyone. At Sunnybrook, it is the Code Orange Steering Committee that really oversees the overall planning strategy for Code Orange. The Code Orange Steering Committee, which we call COSC, it is quite a large committee, and it is an interdisciplinary committee. We have representatives from 29 different departments across the hospital. It is co-chaired by a representative from the emergency department and a representative from emergency preparedness, which current is myself. The overall mandate for the committee is that we are responsible for that general direction for Code Orange preparedness and for setting that response strategy for the entire organization. As a committee, we report directly to our senior leadership. So our executive vice president and chief medical executive is our corporate sponsor, which is quite important for establishing Code Orange preparedness as a corporate priority for the organization. And we are a voting committee, and that's how we move a lot of our decisions and progress forward. And we do have a terms of reference to which the committee is accountable, and I'll go through what that terms of reference looks like in a couple of slides. In terms of who is on the committee, and of those 29 departments, I believe we have about 40 or 45 members. So quite a large group, and it includes a wide range of individuals who are on the committee, including our frontline representatives from nursing, physician, our support services, all the way up through to managers and directors at more of an operational level as well. We have both full members and ad hoc members who sit on the committee. So some of our services who might have an important but maybe less direct or less frequent role in a Code Orange response have an ad hoc spot. Those will be departments, things like our pharmacy colleagues, telecommunications, or communications and stakeholder relations. And we do review that membership and membership list annually, so it is kept fairly up to date. In terms of the terms of reference that we are accountable to, this is really kind of how we set that strategy and direction for Code Orange preparedness. So there's 5 mandates in our terms of reference. First is to guide reviews and updates to the corporate Code Orange policy. That corporate Code Orange policy is quite important for how we direct that response strategy. And it is ever evolving as we incorporate learnings and new literature and so on. And we do decide on changes through a voting structure. We direct individual departments to maintain local Code Orange protocols, and I'll talk more about that planning structure at a corporate and department level in the next couple of slides. We ensure that all plans are aligned and interoperable with each other. Exercises are hugely important for achieving that. We lead a minimum of 4 drills or exercises per year, of which 2 must include a command center. And again, I'll talk a lot more about the different types of drills and exercises that we can use later on. And we identify supplies and equipment which may be at risk and associated mitigation strategies. Now, in terms of moving forward a lot of the readiness and planning or preparedness, we cannot overstate how important buy-in and engagement from staff is. And we're quite fortunate at Sunnybrook to have very good engagement from staff across the organization. Without that engagement, it's very difficult to move a lot of these initiatives forward and to put on good exercises without a good participation. And there's a few different reasons that go into why we have some of that really good engagement from staff. First is an organizational experience with Code Orange response. In the last number of years, we've had a Code Orange major in 2018. In 2022, we had 2 Code Orange minors, and we had a Code Orange alert earlier this year, all of which really keeps Code Orange top of mind for our staff across the organization. But there's also a good understanding of the consequences of inaction and the consequences of a lack of planning, which is a great way of boosting engagement with our preparedness. We take a risk-based rationale. So there's good understanding of the risk for Code Orange at Sunnybrook. Not only are we Canada's largest trauma centre, but we're also one of only 2 adult trauma centres that serve Toronto. And Toronto, of course, there's lots of risk for potential mass casualty. It's a densely populated urban area. We've got major highways, railways. We've got a number of different places that any type of mass casualty could come from. Code Orange preparedness is an accreditation requirement, and this is a dual requirement for us. As Moira mentioned, we are an ACS verified site, so we are accountable in our accreditation both to the Canadian bodies as well as to the RACS verification, both of which mandate planning, preparedness, and exercising for Code Orange. And our last point is that we have excellent physician engagement from a number of different disciplines. It can be a bit challenging to engage with physicians owing to heavy clinical caseloads, call schedules, and shift work. But having their participation brings huge value to both the planning as well as to training and exercises as well. Our planning structure, it encompasses both the corporate level and the departmental level. So we have our corporate Code Orange policy, which does outline sort of that overarching corporate strategy for Code Orange response. And it has some of those general processes like activation, calling the all clear, establishing authority for decision making, and so on. With this policy, we do take a principled approach. And this is something that's quite important. We pull principles both from surge management as well as from incident command system. This principled approach, it's a very intentional approach that we take, and it's something that I really want to highlight today. Because our planning strategy seeks to operationalize those ethical principles that really are the foundation of a Code Orange response. A Code Orange will inherently bring challenges to things like resource allocation, to our continuity of operations, and an ability to provide safe and effective patient care. And there's very real and potentially very severe implications to our operations from that. We are accountable to our patients, to our staff, and to our community as well. And so by taking a principled approach, our response and our decision-making during a response is defensible and transparent, both of which are very fundamental to our planning ethos. There's a couple of other corporate policies that I want to touch on that are all hazard. They are not Code Orange specific, but they are quite important in a Code Orange response. First is the Corporate Emergency Operations Plan, or EOP. This is an all-hazard plan which contains those core capabilities used to manage and coordinate the overall incident response. We have our emergency fan-out procedure, which is our procedure for calling in additional staff to assist with a large-scale response. And we have our Family Information and Support Center, or our FISC, which is all of our procedures for matching patients and families and those reunification procedures. All key departments who are involved in a Code Orange and directly involved in that casualty management will have a dedicated Code Orange plan or procedure. Departments like our emergency department, our operating rooms, medical imaging team, transfusion medicine, and so on will all have that dedicated plan. Whereas some of the other departments, who play a very important but perhaps less direct role, may have more of an all hazards emergency operations plan. So groups like our infection control team or our communications team, both very important in the response, but they're going to be working from an all hazards plan instead of a dedicated Code Orange plan. Where our corporate policy sets the strategy for the response, our department plans are the tactics of the response. They can take a few different forms. We don't mandate to departments what they have to look like. They could be procedures, that could be a plan, it could be a job action checklist. But the idea is the focus will be on those operational actions that staff are taking in the emergency. And we encourage departments to keep them as brief as possible. We really encourage 1 to 2 pages if it is possible. All of these department plans are kept in an appendix of our corporate policy, which does include the date of last revision. This is a new strategy that we are introducing this year in response to some feedback that we've received around the accessibility of our plans and some accountability around keeping them up to date. There's 2 key aspects of our response that I quickly want to touch on, as they are somewhat unique to Sunnybrook, but have worked quite effectively for us in response. First is that our emergency department clinical care leader, or our charge nurse in the emergency department, has the full authority to activate the full corporate Code Orange response. Many organizations give this authority to an on-call leader, like a hospital administrator or director. We keep this with the CCL because in those early stages of a Code Orange event, it's a very dynamic, highly quickly evolving period in time, and good situational awareness across the organization is extremely difficult. It's nearly impossible to achieve in that very early stages. The CCL, that charge nurse, is the person with the best line of sight on that evolving situation in that early phase. And so giving them that authority helps to prevent some delays in activation, and it gives the other departments as much notice of a response as possible. The second approach is our Hospital Emergency Operations Center, or our HEOC, is automatically activated when a Code Orange is activated. So this is our 24/7 on-call incident management structure, and it is automatically activated with a meeting automatically set for 30 minutes after a Code Orange activation, with that initial meeting really focused on sharing some situational awareness amongst the leaders and to help better allocate those resources and plan tactics for the response that is unfolding. So in terms of how we train and keep staff up to date on what to do in a Code Orange, we use a very multimodal approach to training and education for Code Orange, and we hold drills and exercises every year, but which ones we hold does vary year to year, depending on different needs and objectives. I've got quite a few listed here on the screen, and a number of these we're going to go through in some more detail. At the bottom, a couple of things to touch on. We have our emergency department has an e-learning module. It is specific to the emergency department. It provides a high-level overview of the emergency department roles, and it can be completed asynchronously by those staff. We also annually hold a discussion-based spot drill, which comes in the form of what we call our Code of the Month education. This is a scenario-based team discussion, and it is associated with a quick reference guide. And I'll show you what both of those look like on the next slide. We hold this drill annually, every July, if I'm not mistaken, but it is also available to teams throughout the year if they wish to do additional drills. The remainder of the drills and exercises on the screen here are grouped as those which are not specific to Code Orange, but very valuable for Code Orange preparedness, and those which are specific to Code Orange capabilities. And I'm going to go through each of those drills and exercises in more detail in the coming slides. These are the two resources that I was mentioning. On the left, we have our Code of the Month form. It's a one-page document. It presents a short, realistic scenario followed by some general discussion questions, some interesting facts about the code, and some links to additional resources. On the right is our quick reference guide, which is associated. It's a high-level overview of some of the key messages around the activation and the overall response of a Code Orange. Both of these resources we have existing for other hazards as well. They're kept high level quite intentionally, as they are intended for all departments to be able to use. They are not specific to a single department. The spot drill, it provides an opportunity for teams to talk through those initial priorities, initial response actions, and some common challenges or gaps that we know exist when a Code Orange is activated. And we do update these and change these as our Code Orange planning evolves and changes. So some of the training and drills which are not specific to Code Orange, but very important in our Code Orange preparedness. First, we have our family reunification, our FISC. There's a couple of different drills that we can do around our FISC. We could do an activation drill. We could do a tabletop exercise. And this is one of the few capabilities that we can actually do a full-scale exercise for as well. The objective of all of these is around validating and practicing specifically FISC and reunification procedures. Second, we have our emergency fan-out drill, which is an opportunity for our teams to validate and practice emergency fan-out procedures, but it's also an opportunity for us to collect data on how many staff we can expect to potentially report to campus in an emergency. And lastly, we have our HICS training, HICS being our Hospital Incident Command System, which is the IMS system that we use. It provides leaders with an opportunity, with some education on the principles, roles, and general structure of HICS, and it is an opportunity for them to practice incident coordination. I'll note that we're not able to offer HICS training annually, but we can also use tabletop exercises as an opportunity to embed some micro-learning on HICS, which is geared both to frontline workers as well as to our leadership teams. The remainder of our drills and exercises are specific to Code Orange, and they range from fairly small scale, simple events, all the way up to our large scale, fairly resource intensive tabletop exercises. On the left, we'll start with the activation drill. This is quite a simple drill that we can run. It allows us to validate and practice both Code Orange and Emergency Operations Center activation procedures. We have our triage and registration drill. So this is an emergency department specific drill, and it's an opportunity for that team to validate and to practice Code Orange registration procedures, as well as disaster triage procedures, both of which are unique capabilities to Code Orange. Registration, we know, can be a very challenging, can be a bit of a bottleneck as well. So these can be quite high value drills for that team. We have a reverse triage drill. This can be done either as a standalone drill, or we often do it as part of a large-scale tabletop exercise as well. This drill allows all of our acute care inpatient units and our critical care units to practice some reverse triage procedures. They use their current patient census. It's also an opportunity for us to be able to collect data on how much capacity we could potentially create during an emergent surge situation. Next, we have our department tabletop. So these tabletop exercises will involve a single department. Generally, the purpose is to test or to validate either a new or a newly revised procedure. And so it's a great opportunity to provide and to collect some really focused feedback on a single plan or procedure. But it's also a good opportunity for individuals to practice their role on a relatively in-depth level, including things like decision making during a code orange and so on. And last is, of course, the large scale tabletop exercise. And this is probably what we're both best well known for, pardon me. I'll talk a lot more about the tabletop exercise in the coming slides. But what I want to share here is how the objectives for this type of exercise differ from some of the other ones. Where the other exercises and drills listed here are more focused on very specific processes or capabilities, the large-scale tabletop exercise is an opportunity for us to bring together all stakeholders that are involved in the response and really practice the full scale of that response or the full scope of that response. It is, of course, a great opportunity for both individual and team or department level learning. But our primary objectives in that exercise really focus on the interoperability of departments and around corporate response and procedures. In designing this exercise, so we'll talk about the large-scale tabletop exercise for our next few slides. We really treat it as an academic exercise and as an opportunity for data collection as much as it is an operational exercise. In every step of our design, we're always really focused on what are our objectives, how can we achieve those objectives, and what data do we need to collect for planning purposes. And what those specific objectives are do vary somewhat. We're, of course, always focused on our general processes like our interoperability, coordination, and chains of communication. And our overarching, our ultimate objective through everything is to find our gaps and find our opportunities where we can improve our preparedness and move our readiness forward. But we can also include some more specific objectives around a specific process or a specific capability. So in our most recent exercise, which was just 2 weeks ago, we were able to validate our code orange supply stockpiles and our ventilator stock as well. And we also took the opportunity to test a couple of new code orange procedures, which will be rolled out in the new year that the committee recently voted on. Lastly, when we are designing this exercise, we always test to a high level of impact and never to a point of failure. In our experience, this is what will give us the most meaningful data and what will make it the most valuable experience for all of our participants. In this exercise, our large-scale tabletop exercise, it does use a gamification approach, and we really do approach the exercise design as gameplay. We are simulating all aspects of patient care and clinical operations. Everyone is meeting in an auditorium and using truly tabletops. So you can imagine that we rely quite heavily on artificialities to bring in some of that realism. We use game boards, which are very large laminated floor plans to simulate the physical space that departments have to work with. We have playing pieces, which you can see a couple pictures of at the bottom here, to represent all of the staff who are involved in the response, represent existing patients and casualties who are arriving from the simulated incident. And we rely quite heavily on timers as well to bring in a bit of realism to the timeline. All participants are given sort of some standard times for common interventions like patient assessment or intervention, types of imaging, blood work, transport time, and so on. As much as possible in the exercise, we use real-time data from the hospital on the day of the exercise. Things like staffing and occupancy are based on the data from the morning of the exercise. So if our emergency department starts with 6 ICU admits and 4 ambulances on hold, then unfortunately that's what they start the exercise with. If someone is short-staffed that day, then that's the staff pieces that they get to deploy in the exercise. Again, helping to bring in that realism because we know that a code orange is not necessarily going to happen on our best day. And lastly, to give you a sense of the scale and the scope of how big these exercises can be, I've included some of our stats from our most recent exercise, which was just 2 weeks ago today. So we had a total of 90 minutes of exercise play. We had 98 casualty injects prepared. We do not expect them to necessarily go through all casualty injects, but we have enough ready. We had 61 additional injects, and I'll talk more about what is included on those in a couple of slides. We had over 170 participants from 35 different departments, which actually also doesn't include our acute care and critical care units who participated in a reverse triage drill in the morning. For our plans, we had 2 corporate policies that we were testing. We had 16 different departmental plans that were being validated, and we had 4 teams in attendance who were focused on collecting data to form a plan and for planning purposes. So our casualty plan and the way that our game works. Our casualties arrive to the emergency department table, which is pictured on the bottom left there. They come with a triage information with some basic casualty information, and a part of that is included in the orange form on the right there, and an associated playing piece, which you see on the bottom. Each casualty is triaged by the emergency department according to the available and presenting information and placed accordingly on the emergency department board based on where they would be placed in real life. The playing pieces, they're physically moved between departments and within a department based on how a patient would travel in real life. For example, if they need to go for a CT, there is a transport time and patient transport included, and the casualty playing piece will be physically moved to the medical imaging table and held in the CT scanner for the allotted amount of time. Clinical teams have all kinds of interventions available to them. They can send blood work to the labs. They can also request some simulated blood products from transfusion medicine as well. In addition to the casualty injects, we have also developed a number of other injects, which can serve a number of different purposes. Generally speaking, these injects, they provide additional scenarios or challenges which are likely to be encountered during a real Code Orange response. Many of these are based on real life scenarios that have happened to us in response and in every day. Again, trying to bring in some of that realism and reinforcement of what can happen during the Code Orange. Each inject is developed very intentionally to test a certain capability. Like the inject that you can see here that's given to anatomical pathology, who are our morgue players, where they were given a scenario where the morgue is reaching capacity, the transport and storage vendor is delayed, which is intended to prompt that discussion around mass fatality management and what planning has happened around that. We have the inject to the public information officer, which is intended to prompt some discussion in the emergency operations center around what service cancellations might be needed in order to create additional capacity. Some injects might prompt some aspects of interoperability, like the inject here for security, around having media set up somewhere where they should not be, which is prompting security to work with the communications team around the media management strategy in the exercise. And some other injects are intended to keep the play moving forward by triggering certain actions, like the inject here to the ICU team lead to trigger that communication of the reverse triage results to our patient flow team. One additional inject, which we do use on occasion, can be specifically for data collection for planning purposes. So we may have departments document what actions they are taking in a certain situation in order to inform some future plan development. So this is data that we collect from them during the exercise, we collate, and we will give back to those teams to incorporate in their own plans after the exercise. Every inject that we give out has space on the form to document both the actions taken and the outcomes of that inject. These are collected by us at the end of the exercise and are incorporated into our data management and our data collection from the exercise, which in turn will inform our after action report and learnings, which I will talk about on the next slide. So the final piece to our exercise is the exercise evaluation. This is probably one of the most important aspects of the exercise and really how we make this a really meaningful event for our participants. There are 2 streams to our evaluation. First and foremost is, of course, evaluating the response itself. This comes in a couple of forms. It comes in the form of the data collected from the injects, the data from the reverse triage drill, which we complete before the exercise, as well as data that is collected by our evaluators. We have 1 or 2 evaluators per table, and their role is to document those observations and learnings throughout the exercise. Exercise play, once it's complete, is immediately followed by each team running a hot debrief, which is also documented by our evaluators, which they will share with everyone at a cold debrief a few days after the exercise. The second aspect of evaluation is evaluating the exercise design itself. Tabletop exercises are extremely valuable events, but there are a lot of limitations in terms of how we can simulate operations. And so every exercise that we run is an opportunity to improve our design and to make each following exercise a more meaningful and more realistic event. We collect this feedback through a short survey sent to all participants, and our team takes back all feedback that is provided to us, and we incorporate as much as we can for every exercise. The last topic on the exercise that I want to share is a little bit on the debrief, and I could talk about this particular topic all day long, but there's a couple of highlights to our approach that I want to share. We do use the same standard framework that probably most people here have seen, and that's quite widely used and comes from the US military. It's, what went well, what didn't go well, and what opportunities can we identify in order to improve in future. And that's the framework that we use both in our hot and our cold debriefs. But there's a couple of sort of strategies on top of that which we employ, which are not always standard, but work quite effectively for us. First is the overarching protection of psychological safety during debriefs. Not only is this fundamental to debriefing itself, but it is of particular importance in this particular group when you have an inherent power balance present. And in these debriefs around these exercises, we do have both frontline staff as well as senior leadership present. So it's really important to have a space where every participant who is there feels welcome and supported to contribute honestly and transparently. And that's a top priority for us in our debriefs. We treat our debriefs as an open forum brainstorming sort of session, and we document all feedback, all questions, and all suggestions, regardless of whether they're feasible or not. We use that verbiage and honor that verbiage used by participants and take that as part of our data analysis, so we don't ever lose the meaning of what they were saying at that time. We have talked a lot about data collection through the exercise. And the aftermath of these exercises become an exercise in large-scale data management and analysis. And I am deep in that phase currently from our last exercise. And we draw some principles and strategies from qualitative research to help in coding, in analyzing, and in managing all of that data that we collect. Qualitative research skills, it is a competency that our team in emergency preparedness has here, and that does really allow us to treat the exercise as an academic one. So that data analysis process is how we come from all of that data to produce our overall learnings, our themes, and how we develop objectives and recommendations to improve future preparedness, to move readiness forward. Recommendations which hopefully are feasible, realistic, and of high value to planning. This is what comes together to form our after action report, or our AAR, which in turn helps to inform the work plan for the Code Orange Steering Committee for the months and year upcoming. So that sort of brings us full circle on preparedness within Sunnybrook. We've thrown a lot of information out here, but I'm going to pass back Moira now to discuss the last big piece that we haven't talked about yet, which is Code Orange preparedness at the system level.
Thanks, Jayme. And I know that we are kind of hitting time, and we do really want to have a lot of discussion. And I see the Q&A is kind of racking up there. But the point I want to make is that while we've shared Sunnybrook's approach and our experience, at the end of the day, a Code Orange always involves and impacts the broader health system. Every single day, we are highly reliant on informal and formal forms of mutual aid, and we never have enough capacity in the system for emergencies like this. More than that, when an organization experiences a Code Orange event and they have to seek diversionary status, it does take some time to recover from that event. And implicit there is that our recovery means that our partners take on that patient load for some time. So there's certainly always a burden to our partners, not only because they're engaged in the response, but because they might be shouldering the impacts of our unavailability. In the Greater Toronto Area, regional preparedness really is facilitated through a really large and impressive committee. And I know many of those delegates are here today and joining us today. We have a committee of about 30 organizations, including the 19 hospital networks in the Greater Toronto Area, as well as each and every partner that facilitates Code Orange response in real time. We believe strongly that our ability to plan together is how we will respond together. And so I think it goes without saying that the system must work together to plan for and respond to Code Orange emergencies. Before that emergency happens, no doubt for the emergency management colleagues around the table, we need to be leaning into MOUs, understandings of our capabilities so that we can, on that day, work collaboratively without barrier. We also need to grow partnerships. Code Orange and mass casualty response does not happen in a silo. Engaging with our partners pre-event is an accreditation requirement. And while it's challenging to maintain those working relationships with our paramedic and police colleagues, they are invaluable to our preparedness. During that emergency, our hospital partners and our paramedic, police, and municipal partners, of course, have to work collaboratively to be engaged for the response. That might look like creating capacity in the system by expediting repatriations or load balancing patients. It might also look like sharing supplies, trauma supplies, blood products, and so forth. And at minimum, we are all involved in coordination of that emergency response. So that really culminates our presentation today. And as promised, we wanted to leave 5 items that we believe our colleagues can take on and bring back to their organizations, acknowledging fully that we didn't get here overnight. It took years of developing that culture, that preparedness, that planning. We want to be intentional in communicating that. But mindful of that, we do think there are some attainable steps that each and every one of us can take back. One of those is to focus on those micro-learning moments. Jayme shared a number of examples of those. Those are quick resource, not resource intensive, and they really do help with that buy-in. Low resource drills have high impact. Even if 1 or 2 people walk away from that with a new or renewed interest in emergency preparedness or a better understanding of your expectations of them in a response, you are richer for it. So please find opportunities, even just to do a fan out exercise or something small, just to kind of get people thinking about emergency preparedness. Connect with your paramedic and police services partners. I cannot overstate this enough. We cannot have coherent action if we don't have a good and honest understanding of each other's roles, capabilities, and how we will work together. Every mass casualty inquiry has highlighted that this connection needs to exist. And it's not a connection you're going to be making in that emergency response. So please remember that we do this for the victims and their families, and we have to work collaboratively, even in our planning, to acknowledge the gaps there. Connect internally, you will find champions, I promise you. We find champions all over the place. They are the people and the resources will get you where you need to go. We have one physician in particular. He has attended more than 10 exercises. You have those champions. I guarantee they are there. And the last point I want to make is if you're joining us from municipality, if you're joining us from some other critical infrastructure, please connect with your hospital partners. Hospitals are critical infrastructure. We never turn offline. We are always there for our patients and our communities. And while we have unique planning deficiencies and gaps, we also have unique capabilities as a system. So again, we want to thank you so much for your time today, and back over to our wonderful moderator for any questions.
Certainly. I was going to say, I don't even know where to begin. You guys really packed a lot of information in there as promised. There was certainly some communication that was going on in the chat, as well as lots of questions that ended up coming through the Q&A. Lots of, commending you folks, especially when it comes to the exercises that you're running. lots of questions around this. I know that our coordinator answered a couple of those questions because there were some folks that were interested in perhaps getting in contact with you. So I would say to anybody that's, interested in that, we won't provide your information right now, but you can go through our York coordinator. It'll act as a little bit of a liaison. So if there's questions that people have that they would like to, carry on the conversation with Jayme and Moira, you can do it through that way. So I don't want you to think that we aren't addressing those questions. So where to start off? I was going to say there's a couple here that could probably be answered almost simultaneously. So somebody was saying, from photos and from conversation, clearly you've had external partners that have been involved. Somebody you could see in the photos like EMS is there. So how do you get the community partners involved? So like, how are they involved in your actual exercise, kind of planning and coordination? And a subsequent question was asking, do any of those external agencies, get involved as a part of the evaluation process? Are they there to audit the tabletops? Are they providing feedback? So what does that look like? So maybe I'll start with that as one kind of question.
Also, do you want me to take it?
I can take the first part there. I'll clarify quickly. The picture that you're reacting to is actually our security guards who were in that photo. But we do have external partners who do participate. And at our exercise just a couple of weeks ago, we had some colleagues from Toronto Police and from the OPP as well who were in attendance. A lot of that really comes down to what Moira ended with around engaging with them and having those connecting with those partners, and then inviting them. Send the invite out to have them come by. I think you'll find more often than not they'll jump at the opportunity to come connect and ask their own questions and have some discussions with staff around that response. And then I believe the second part of the question was around auditing tabletops.
Yeah. So generally, so I guess another important element to Sunnybrook's story is that we're a regional center. So we work with between 4 and 5 separate police and paramedic services to do this work. So we don't just work with one of the other. And so actually in the past, we've not had external partners audit the evaluation, but we've had them heavily involved in the design. When we opened up, we talked about a 2019 emergency preparedness exercise we did that involved 4 paramedic services and 3 police services. Our paramedic colleagues helped us actually to pre-triage according to the field standards, all of our casualty index, and our police colleagues helped us develop a scenario that was comparable to the 2015 Paris attacks. So even at our planning tables, we include our external partners. So no, we don't really involve them in the evaluation, but that's something for us to maybe marinate on and reflect on. So we appreciate that thought.
You also just touched on something there by talking about triage. So one of the questions that was in the Q&A was actually if you were interested in expanding, especially considering there are some folks on the line right now that might not be in a hospital setting, but they might be kind of healthcare adjacent. We're just wondering as far as if you could expand on changes to kind of normal triage process during a mass casualty incident.
Absolutely. I love disaster triage. In normal triage times, we use our EC task, which is set out across Ontario. There's 5 levels that and a patient is assessed based on all of the presenting signs and symptoms in front of them. When we move to disaster triage, and there's a number of different systems for disaster triage, most commonly you'll hear the SMART or the START system. That's where we tend to go to that color coded, that red, yellow, green, and sometimes black as well for triaging. The big difference, one, it has been shown to be faster triage than CTAS, but the big difference is now you're looking at resource allocation. As soon as we are looking at triaging a patient as black, we are offering them palliative care services at that point because we no longer have enough resources to offset the risk for that patient or the risk of the chance of them surviving based on the number of resources put into them. So it's a hugely ethical decision that it is made, and how we support that decision and how we define and outline that system and those criteria is a major discussion with our Code Orange Steering Committee right now, and one area of our planning that we do really want to focus on next.
Great. I was going to say, every time you're answering one question, I feel like it connects back to other questions, and there's just so many to pull on here. So I was going to say, so one thing that I realized you were kind of high level as you were giving a bit of a skim, but might be valuable to explain to folks on the call, is obviously you have a staged approach to your code orange. So unlike some of the other codes for folks that might be familiar on the line, you hear a code blue. Typically, you don't have multiple stages of code blue. You hear something like code orange. At your organization, it looked like there were 4 different levels. So just touching on the fact that we have differences between hospitals for how code orange gets broken down. But this feeds into, I think, a question where you're talking about your code of the month education, and you highlighted the code orange code of the month. And the question was, who's facilitating these sorts of spot drills? And are they something that's facilitated by your team, or are they delegated to local leaders or educators? So any insight on that?
Our spot drills, we do delegate. So our team creates them, we distribute them to all leaders, and then any team leader, whether that's a manager, an educator, an advanced practice nurse, a supervisor, anyone like that, can lead that drill with their own team. And I did see a question. We are only a team of 4 here at Sunnybrook, so we do not have the ability to run these drills with every team as much as we would love to.
Yeah, I was going to say, I was waiting for you to say we've got this squad of 20 people that are helping. But I think, again, for anybody on the line, you can see how hard it is for these really, really important healthcare hubs that are doing so much with so little. So you're finding as many efficiencies as you can. And we commend you for your ongoing efforts and high quality delivery of your emergency preparedness program. I think there's a couple of questions that kind of touched on debriefing and also perhaps the concept of lessons applied. So one was saying, what defines your hot and cold debrief, content sensitivity, time when it happens, and then somebody, yes, sort of asking, lessons learned versus lessons gathered. So any sort of kind of additional context around your debriefing process and your collection.
Sure. So there's a couple of layers to that question. In terms of hot and cold debrief, the definitions are, they vary a little bit through the literature. For us, it is more or less based on the amount of time that has elapsed. It can also change a little bit the scope or the scale of it. Our hot debrief around the exercise is the one that is done. It's done by individual teams, and it's done immediately after the exercise. So we provide them with a protected 30-minute time slot immediately after exercise play ends, for all teams to, within their own team, have that discussion of how it went, what can they improve, and what feedback can they share. Our cold debrief, we hold a separate time for that. We let our evaluators marinate in their feedback a little bit, collate some of the feedback from their team. We hold it a few days to at most a week after the exercise. And it's a bit more of a high level. We're looking for a summary of what are those key points, those key messages from our participants and from our staff of what did work quite well and we should keep doing or incorporate into our plans, and where are those gaps and learnings. It can change a little bit the timeline for a real event, just owing to different pressures and schedules and so on. But as we're booking these exercises and this cold debrief quite a ways out, we try to keep it within a week of the exercise. And then the second part of that question was around lessons learned versus lessons gathered. And it's an excellent question. It's a very common challenge, and we are certainly don't have the perfect answer to it. I find by coding our lessons, by grouping them according to theme, it does help form a little bit, a bit of a trend and idea of what some of those common themes and those recurring themes between exercises and between real events. In terms of a more formal documented tracking system for our lessons, I think this is something that we have talked about as a team and is a future state that we would like to develop. Having the Code Orange Steering Committee, though, is hugely beneficial in tracking a lot of these when we do create that after action report, which contains all of the learnings as well as the improvement plan with all of those recommendations. That is distributed to not only the evaluators and participants of the exercise, but to all the members of our Code Orange Steering Committee. And so that helps with a little bit of the accountability amongst the committee in terms of who is doing what recommendation and tracking some of the status of them.
Excellent. So even just talking about tracking, and you said you had a number of different departments. I think you had 25 different departments in the one example that you were giving that were participating. So one of the questions, I think actually it was the first question that got populated in the Q&A, was asking about how often are the department plans updated and what does quality assurance actually look like on those?
Currently, our department plans, we ask for them to be updated annually. I've heard some feedback in the last year that is a really frequent update that they've been asked to do. So it is a discussion that we're going to have as a committee, whether there is still value in keeping it as an annual update based on, and we do usually time it about now after an exercise so that we're really bringing those learnings in, or whether there is good sense in pulling back slightly in that timeline. And I apologize, there was a second part of that question.
Quality assurance. So we use our exercises to apply the quality assurance lens, and that's why we need our department stakeholders to let us know what will be challenging for their teams so that we can build an exercise that can help us assess the quality of those plans as well.
So I only have time to do maybe a couple more questions. So I want to apologize to everybody that has a question in the chat. Again, you can always reach out to our coordinator to be able to get some of those extra questions out, and we'll try and answer them as best we can. Clearly, this is a big topic. And again, reflective of that is somebody asking what I sort of touched on, I think, earlier, which is, can you provide a description between something like a Code Orange minor versus a Code Orange major? So again, we've got these different levels that are acknowledged at different facilities.
Yeah, it's a great question. And different hospitals do it differently. Not all hospitals use a tiered approach. Some only have an alert or a standby and a response. Others divide that response into a minor or major or similar type tiers. Generally speaking, and most hospitals define the definition based on the number and type of resources that are required for the response. So generally speaking, most Code Orange minor tiers are defined as being able to respond using resources on site or by redeploying on site resources, versus a Code Orange major, which is often defined by current resources or current on-site resources being overwhelmed and requiring additional resources from outside, whether that's staff coming in or additional equipment or so on, in order to support that response and the surge that's coming in.
So I'll take this maybe as the last one because I realize we're really short on time here. Is we did have somebody, they were anonymous, that was commending that it was a fantastic webinar and they really appreciated everything you were sharing. And that's been coming through the chat as well. If you guys want to give yourselves a pat on the back for all the positive feedback, everybody needs that kind of positive reinforcement. But somebody was saying, they really loved all of your insights on data collection, the design, but could you share some of the challenges maybe that you faced in the process? And so any tips on defining outcomes effectively in this context? So we'll kind of leave it for you to talk about something that you've, struggled with and turn that into a success if possible.
Do you have one top of mind?
I gotta marinate for a minute.
Well, I think every hospital went through the toughest 3 to 4 years of our lives, and certainly as emergency managers, we were all in the thick of it. We lost even Sunnybrook. I mean, we're presenting our plan, our approach, but even we lost our footing and our momentum. And I want to normalize that. A lot of hospitals are still struggling to get their momentum back, trying to get that engagement, that buy-in. Turnover has been significant. The average age of a healthcare worker looks a lot different than it did pre-pandemic. So I want to be intentional in saying we have that challenge too. Every single day we're operating at over 100% capacity here at Sunnybrook. And so all of those still daily operational challenges exist, yet we have to demonstrate that this is still important on top of that. So I think I think that's one thing that I'm super mindful of as a challenge. Jayme, anything specific to Code Orange?
Or to data collection?
Data.
I think that around data collection, the biggest challenge is around data management. At the end of the exercise, I mean, we had 61 injects, we had the reverse triage drill, we have many pages of data. You know, I have a stack sort of this tall on my desk of forms from data, just of data that it is collected, which all has to get inputted, you know, from paper format into a more meaningful, more digestible sort of format. I don't know that I have a really great strategy to make it so much easier. I don't want to understate how much work it is and how many hours it is in that evaluation piece and informing our after action report. It's not a quick process, and it's not an easy process.
So I know we've reached time, and I'll flip it back to our fantastic coordinator for helping facilitate the series. But I want to thank each of you personally, on behalf of all of the attendees, for taking part and closing out this 6-part series with us. So many takeaways, lots and lots of gratitude in the chat. We couldn't be more proud of all of the efforts that you undertake on a day-to-day basis, and for sharing all of these learnings with us. So thank you so much. Francesco, I turn it back to you to close us up for the series for the year.
Thank you so much. Yeah, I would just like to echo Misha's thanks to both you, Moira and Jayme, for taking the time to be here, for that great presentation, for answering as many questions as we were able to get to. There was a lot, and thank you, of course, to our audience for participating, for joining us, as always. There's a lot of thanks for both of you in the chat as well, from all of our participants. So a big thank you to everybody for making this series such a success. As most of our participants will probably have seen, this is the last session for the year, for 2023, of this first kind of cohort of sessions, I guess you could say. But we will be back in the next year, beginning in February, back with more monthly series. So stay tuned for that. The registrations will probably be the same ones that you already have, so you probably won't have to register again, but just be on the lookout in your emails for the next sessions that will be coming up, like I mentioned, starting in February. So we hope to see you all there for the second round of Emergency Management in Hospitals and Healthcare Speaker Series. And with that, I would just like to wish everybody a good day. And one last big thanks to everybody again.